pass it on to Professor Harun Ahmed, acting at Medical University.
Ji, Bismillahirrahmanirrahim. Can everybody hear me? Ji,
Yes, we can hear you.
Ji, thank you very much. Asim, can you allow me sharing my screen? अगर आप मुझे screen sharing allow कर दें तो I can show you few slides. Meanwhile, what I want to say is, honestly speaking, there's a lot of things happening with COVID around. A lot of information pouring in. We think that we have more information, we have more knowledge, we think that we have more guidelines, but actually it's adding on to more confusion. What I would try to do is screen sharing allow करेंगे तो मेरी screen नजर आएगी, please. What I would try is जी ठीक है. Over the next 10 minutes or so, what I would try is I would try to make it as simple as is possible. Right. One thing that has happened, at least in Punjab, is the placement of the patients. Placement of the patient is part of management. So we now know that these patients can be those who are suspected cases or those who are confirmed cases can be placed at their homes as well, depending upon the facility at their homes, and there are committees formed for that. We already know the categorization, the asymptomatic. Mild would be those with non-specific respiratory tract symptoms. One with the radiological evidence of pneumonia categorized as moderate. Any of them having danger sign would be categorized as severe COVID case, and they can be complicated with sepsis, septic shock, ARDS, etc. Now, other than the fact that they are unwell because of their illness, if they are moderate or severe, they would need admission. There are other considerations that would need to give for their decision about their admission. That includes severe malnutrition, very rampant in our setup, primary immune deficiency, those who are on immunosuppressive therapies, those who have got chronic lung diseases or congenital heart defects, chronic kidney diseases, diabetes, and of course the social reasons where the children cannot be taken care of at home, or the home environment is not appropriate for their isolation or quarantine for that matter. So as far as management of symptomatic patients is concerned, the most important thing may it be mild, moderate, or severe, infection prevention and control, very, very important, contact and droplet precautions, and if there is AGP involved, airborne precautions as well. I think Professor Taisab has talked about investigations, but what I would say is that in mild cases, perhaps other than confirming the diagnosis with a PCR, you would not do a lot of tests. Now, the other thing is the role of chest X-ray. There are studies which have suggested that even in mild symptomatic cases, there might be early changes on chest X-ray. Are we going to do chest X-ray on all those who are mildly symptomatic or not? It's a big question. At the moment, the consensus is not to go for a lot of tests if they are not really symptomatic as far as the severity is concerned. We need to make sure that they are well hydrated, paracetamol, and avoid NSAIDs and antihistamines. We all know that. Now, in moderate symptomatic, these are the ones who would, in addition to have cough and coryza and fever, they may have other signs of, say, tachypnea or breathlessness, and they would have radiological evidence of pneumonia. Here, you would like to admit them, do their baseline test. Of course, chest X-rays would be very, very important. The other thing that I want to highlight over here is to look at the trends of the lymphocyte count and the CRP, as has been mentioned earlier, that this would be the prognostic value. So we need to look at the trends and see how the lymphocyte count is going on and what is happening with the CRP. That would be very helpful in prognosticating the outcome of these patients. Hydration, if they are not able to take orally, intravenous hydration, we need to make sure that their nose is clear, especially the nose of the small infants. If they need nebulization, these bronchodilators, only if they need bronchodilators. We tend to avoid nebulization, and we would give them these bronchodilators with meter dose inhalers. Empiric antibiotics, of course, although the antibiotic, we know that there is no role of antibiotics in viral infection, but lower respiratory tract infection in itself is so common in children. And if they present with moderate illness and there are patches, perhaps one would consider starting with the antibiotic right away. Otherwise, there would be role of antibiotics to prevent secondary bacterial infection. The antivirals, chloroquine and the hydroxychloroquine that we are so keen to talk about and discuss about, I'll come to that after a couple of slides. In severe cases, in addition to what I have said earlier, I think very important to look at the D-dimers and the ferritin level. Again, that would give you an idea of the severity of the illness, and that would be helpful in prognosticating the patient. You want to see their blood gases, their partial pressure of oxygen, and the CO2, make sure that they are in the normal range, or you have to intervene depending upon what they are doing. Professor Taisab has mentioned the possibility of severe cases having hypercoagulable state. So the need of coagulation profile is very, very important. Now, this is something which is well established in adults. There are very clear-cut guidelines to look at the coagulation profile and to anticoagulate adults with severe illness. There are certain centers which are doing this for children as well, but there is no consensus, there is no clear-cut guideline or any clear-cut evidence as to its utility as of now. So airway management, oxygen therapy, we are going to touch on that a little bit in more detail. Mechanical ventilation, not at this point in time. Fluid balance is very, very important. We want to perhaps keep them in little negative fluid balance, because positive fluid balance would cause more problem with your respiration, oxygenation, and other things. Of course, if they have clinical features or the criteria fulfilling sepsis or septic shock or ARDS or multi-organ dysfunction, you need to manage that as well. Now, these are the therapies which I have, we call it investigational therapies. Convalescent plasma has got a lot of success. Steroids, antiviral medications, hydroxychloroquine, chloroquine, azithromycin, immune modulators, and there's some talk about the role of zinc and vitamins A, D, C, etc. So we are going to see about that. So airway management is important, because if you want to, in some of the patients, you would end up passing endotracheal tube, and we know that passing endotracheal tube is an AGP, an aerosol generating procedure. So one need to be really very careful. So the most experienced person around should intubate these patients, preferably one who is trained in intensive care or one who is very well experienced, or an anesthetist. And we need to do that in a very controlled environment. Generally, we tend to intubate the children without taking care of what we call the rapid sequence intubation steps. So here it is very, very important to follow rapid sequence intubation steps. Oxygenation, as far as the adults are concerned, they are advocating non-breather masks for up to a flow of 15 liters per minute. And there was concern earlier on about the possibility of AGP with the use of nasal cannula or nasal prong, and specifically with the use of high flow nasal cannula. But studies have shown that the risk is not great. So children tolerate oxygen with nasal prongs or nasal cannula better than with the mask. So I would suggest that we go for nasal prong or nasal cannula, and we may start with half liter per minute, and then we can increase the flow depending upon what the saturations are doing. We can go higher than that. High flow nasal cannula oxygen, although it's advocated, is a lot of studies, lot of things coming up in this regard. But I know that most of our setups really do not have those high flow nasal cannula setups. We need to have a little separate setup for that. But if available, it is absolutely imperative to go for HFNC before we decide to intubate these patients. Again, with CPAP, there was concern that said CPAP might cause aerosol generation, but considering the safety and the success with CPAP, it is now recommended that you try CPAP before deciding to intubate these patients. Now, because their lungs are really very bad, they have sort of picture of ARDS. Prone positioning has got very important role, and it is advocated in the case of COVID ARDS as well. 12 to 16 hours in a day. Uh, Hydroxychloroquine, chloroquine, people have been using it for all sort of things, for prophylaxis, for treatment of severe cases. But now the evidence is pretty clear. Now the largest study that has come up has shown, what they have done is that they have compared four groups actually. In one group they were given combination of azithromycin and chloroquine, hydroxychloroquine. The other group was given hydroxychloroquine or chloroquine. The third group was given azithromycin, and the fourth group was given none of these medications. And guess what? The outcome as far as the mortality is concerned was highest in the group which was given the combination of azithromycin and chloroquine slash hydroxychloroquine. And that was followed by the group which were given hydroxychloroquine and chloroquine. So then there are concerns about QTC and all those bits. So now the consensus is that for severe and critical cases, because there are more chances of having them mortality, we really do not know why, the cardiac issues or the otherwise. Now the recommendation by Corona expert and advisory group is not to give these medication to severe or critical cases. Of course, there is no evidence to suggest that there is role of these drugs in the prophylaxis or even in the milder cases as far as children are concerned. So they have gone to extent that even if the child, the patient has been on hydroxychloroquine or chloroquine, you need to stop them if they fall into the category of severe or critical illness. So the only thing that perhaps can be done is giving them with the permission of IRB in the trial settings. Anticoagulation, again, another something which has come up recent in the adult guidelines and is considered now the standard of care in all adult patients with severe or critical COVID infection. And now the CEAG guidelines are to include all adults with severe and critical COVID patients. However, if there is increased risk of bleeding, you need to exclude those patients. You need to make sure that their platelet count is appropriate, is above 50,000 at least. And to begin with, if it is less than 100,000, one would be more cautious. We need to make sure that their prothrombin time INR are appropriate, and you also need to look at the FDPs and the D dimers. So you need to monitor once the anticoagulation therapy is started by the INR and the platelet count. And if there is evidence of a derangement in this coagulation profile or platelet count, or there is evidence of bleeding, you need to stop this anticoagulation therapy. Now, there are certain centers which are just giving prophylactic anticoagulation, and you would all understand that the dose of prophylactic anticoagulation is less compared to the therapeutic dose of the anticoagulation. The CEAG has come up with the recommendation that if the D dimers are less than 1,000, you start the subcutaneous or oral anticoagulation in the prophylactic dose. However, if the D dimers are less than 1,000, to go for the therapeutic dose. So enoxaparin or the oral anticoagulants, both are being advocated, but perhaps for severe or critical patients, this would be the low molecular weight heparin that would be more appropriate. The immunomodulators, Tocilzumab is one, this is anti-IL-6 receptor antibodies. It has shown consistent good results. It has been used as a trial drug, but the initial results have been really very encouraging. But our guidelines of CEAG are to, if you want to use Tocilzumab in severe cases, this would be only for the severe or critical cases. You have to follow the IRB approval, and as far as Punjab is concerned, the IRB approval has been, the hub is PKLI. You have to involve the team in the PKLI before you start anybody on Tocilzumab. The priority would be for those patients who have got progressively declining lung functions, or who are at risk of going on ventilator, or who are already on ventilator but less than 24 hours. Because if they are on ventilator more than 24 hours, the chances are that they might have developed hospital-acquired nosocomial infection, and then this concern about Tocilzumab precipitating the infection, especially the fungal infection. This is the criteria which has been set forth. I'm not going to go into the detail of that, but I think one need to have this criteria before offering tocilizumab to any of these patients. Steroids, there is no role of steroids in COVID as such, but as far as the COVID ARDS is concerned, there are promising results of use of steroids in COVID ARDS if started earlier. The CF recommends that if CRP is above 1000, again, this is related with the inflammatory response of the body. So if CRP is very, very high, that would suggest that the cytokine storm is really very strong if the inflammatory response is very high. The methylprednisolone is recommended for 5 days. I have not come up with any study, any guideline, any evidence as far as pediatric population is concerned, where they have advocated steroids for children with COVID ARDS. Children really, very, very little number of children go on to develop severe or critical illness. Even with this little number of patients, we don't have robust evidence to suggest their routine use. Adults routinely go for azithromycin, but I don't see any reason to use azithromycin as first-line antibiotic for our children, really. So depending upon the local policies and depending upon what is happening with the patient, you would decide for the first-line or the second-line antibiotics. Antivirals, a lot of antivirals have been tried. There is one which has shown some success. I'm going to just touch on that. We talked about convalescent plasma. Success stories are coming not only from abroad but also from Pakistan. Tocilizumab, we have talked about that. We have talked about hydroxychloroquine. Of course, big no to hydroxychloroquine and chloroquine as a routine. This is one which is showing promising results, and now adult patients are routinely put on this antiviral if they fall into the category of severe or critical illness. I'm not sure that children are routinely given these drugs, but something to consider about using this drug. But unfortunately, to my knowledge, it is not available in Pakistan as yet. Perhaps some of the pharmaceutical companies are trying to get it manufactured in Pakistan. So once it's there, so perhaps for severe or critical patients, it would be helpful. So there have been earlier trials with other antiviral drugs and with certain antiprotozoal drugs as well. But really, the jury is still out. Really, we don't have any concrete evidence to use anything except one antiviral over here. So with that, I stop. I think I've already overshoot my time, and then if there are any questions, take those. May I ask a question, Harun Hamid here? May I ask a question from Dr. Abid Qureshi, please?
Yes, Arun, go on.
Dr. Abid, as you rightly mentioned that CT scan is really very helpful. Now, our difficulty is that in most of the hospitals only there is one CT scanner, and then the radiology EEG team would be reluctant to get the COVID patients in the scanner because of the risk of the exposure. Now, my question is, would there be role of chest ultrasound in addition to chest X-ray, which can be done on bedside in these cases?
No doubt, chest ultrasound is an alternative tool, but this will not add any other positive findings as we see the findings on X-rays, because as I've already discussed, the opacities which we see on X-rays that will be seen as a multiple B lines on ultrasound. So ultrasound will not have an additional upper edge compared to the findings on X-rays. And regarding the first question about the use of CT scan, this should be customized center to center. If any center have more than one CT scanner, then they may dedicate one scanner for the COVID positive patients imaging. Otherwise, as far as the findings on X-rays are concerned, if the findings are more severe enough, which we have seen on CT X-rays, having CT scan will not change the outcome of the patient or the severity of the disease. It depends upon the hospital's policy, whether they want to send these patients for CT scan. If they want to do, then proper information to the radiology workers over there, so that they must not be the other patient attending at that particular time. And the most important is the disinfection after getting the imaging done.
Thank you. Thank you, Doctor. Another question from Dr. Mumtaz Lakhani about how many patients are there at Children's Hospital and your hospital. I can answer Children's Hospital, and I think Harun can answer your hospital. We have so far discharged 21 patients from Children's Hospital, and at the moment we have 4 confirmed cases admitted at Children's Hospital. I must admit that the number of patients who are symptomatic, out of these 21, only 3 were symptomatic, who came in with pneumonia. One of them, we almost went to the level of ventilation, but fortunately didn't need ventilation. But the other patients, as per Government of Punjab policy, were actually asymptomatic patients. Arun can answer the Mayo Hospital part of that.
Thank you, sir. Currently, we have 34 children admitted at Mayo Hospital with confirmed COVID. And then there are, I think, 4 of them who are admitted in rooms, suspected COVID. Their results are awaited. Already, we have discharged more than a dozen patients who were stable and were sent home. Most of these patients are those who are with their mothers or fathers or the family members. We have, the last time when we had this webinar, we did not have any patient who would fall into the category of moderate or severe COVID. But last week, we had 3 patients who had very typical history suggestive of COVID. We lost one of them in our ICU. The other one absconded, and we are trying to trace him. And the third one seems to be improving, was with wheezing and all that. Then we had a very typical patients with complete ARDS. That was a very interesting case. I want to discuss that case for the knowledge of everybody. That 11-year-old girl had a fracture, and for fracture she went to various places, to GPs and to perhaps these Jaras as well, and then had her POP done at Services Hospital. After that POP, after like about 4 or 5 days, she developed high fever, although there were no respiratory symptoms, no cough, coryza. But after a couple of days of febrile illness, she developed respiratory distress and was then taken to Services Hospital again, and then to another hospital, then another tertiary care hospital. Landed at Mayo Hospital in a very bad shape, was put on ventilator straight away, had bilateral ground glass opacities, very typical of ARDS. Her CRP was very high, more than 100, and her D-dimer was 1500 something. Her PCR was sent. Unfortunately, the result was not really very informative. We lost that girl. So having said that, I think now that the lockdown is over, I'm sure that we are going to see more cases of COVID who come with moderate to severe illness. This morning, we had our Board of Studies meeting in the Department of Pediatrics, and I was suggesting, and this is a suggestion, there are our seniors sitting at Children's Hospital and on line as well. I would suggest for the House to say if it is okay or not, that any child, with now the lockdown is over and we know that the virus is in the community, so I suggest that any child who comes to our hospital with pneumonia, radiological pneumonia, we need to have high index of suspicion for COVID. Because 1, virus is in the community. 2, it is not necessary now to have a definite contact, because there would be large number of asymptomatic caregivers and family contacts roaming around. So this is my suggestion, and at Mayo Hospital we are trying to figure this out. So we are trying to figure out that are we going to keep all respiratory patients with low respiratory tract infection in a separate place till we have their PCR result, positive or negative whatsoever. I think this is something that we need to look into.
Can you hear me?
Sir, we can hear you. So thank
Okay. Thank you very much. Very useful communication. All the speakers presented very well. We are quite up to date. A few points. One is that when you're analyzing the patients, especially at King Edward, since they seem to have more with Professor Harun right now, an analysis of the state of nutrition and the various vitamin deficiencies should also be included, and that will tell us the status of their general health and if that had any impact on the as a underlying condition on the severity of this particular condition. The second point is that I'm glad, and I have on various platforms been against the use of azithromycin and hydroxychloroquine. I'm glad that azithromycin now has not been verified to be used in this situation, because I don't know about others, but even now we continue to see XDR, typhoid, and unnecessary and general use of azithromycin for this condition should now be discontinued. We shouldn't do this. And I see this in adults, not only in children, where they continue to use this empirically. And lastly, what is the, I haven't come across the use of remdesivir in children. So I was wondering whether there is any study or any trial of this drug being done in children at the present time, since this drug is going to be available in Pakistan, hopefully soon. So just a few questions, but very well done session, and except that the quality of sound was a little bit, could have been improved a little, but I think very useful. Thank you.
Thank you, sir. If I can quickly, of course, there is no recommendation for any of the antiviral for COVID in children. There was one, not a consensus statement, but there was a joint statement that if you have to give any antiviral in severe cases, pediatric patients of COVID, you might consider using this drug. There are a large number of trials that are going on. In UK, only I am aware of at least 3 trials with single antivirals and with combination of antivirals as well. So the results are still, of course, pending, but there are a large number of trials happening. So we'll see what happens with the results of those trials.